Imagine your car's check engine light starts flashing red on your dashboard, right? And your mechanic's brilliant solution is to just, I don't know, slap a piece of thick, opaque tape over it.
Right, just out of sight, out of mind.
Exactly. You don't have to look at the warning anymore, sure, but the engine is, it's still fundamentally breaking down while you drive.
Which sounds entirely insane when you put it like that.
Right. But if you are treating diabetic foot pain with a generic drugstore insole, that is exactly what you are doing.
It really is. It's a perfect comparison.
So, welcome to part 4 of our diabetic foot care series. Today, we are moving past that generic advice, and we are looking at the actual reality of specialized clinical intervention.
And it's such a critical distinction to make for anyone listening, because if you've been, bouncing from doctor to doctor, paying specialized copays just to be handed a generic pamphlet and told to
just buy better shoes or whatever.
Exactly. Buy better shoes.
Yeah.
You already know how incredibly frustrating that retail medical maze really is.
Oh, for sure.
So today is about understanding exactly why a board-certified Pedorthist's role is the definitive factor in keeping diabetic patients mobile, safe, and, most importantly, independent. We are talking about true clinical care versus, well, retail guesswork.
Okay, let's unpack this, because today's mission for this deep dive is to truly understand the role of a certified Pedorthist. And to do that, we have this incredible stack of clinical notes and practice materials from Michael L. Ashley.
Yeah, these notes are fascinating.
They really are. So he is a board-certified Pedorthist with over 20 years of clinical expertise based out of Cedar Hill, Texas, serving the greater DFW area.
Right, the Dallas-Fort Worth area.
Yep. And right off the bat, going through his practice model, you see this massive blinking neon sign warning people away from that retail guesswork you just mentioned.
Yes, and he warns against it because there is a vast, vast difference between buying a product and receiving actual clinical care. When you walk into a retail orthotics store, or even a pharmacy, the primary objective of that environment is sales. They are structurally designed to address surface-level symptoms.
Like your heel hurts, so they sell you a gel cushion for your heel.
Precisely. Or you have arch pain, so they sell you a generic arch support. But clinical pedorthic care, like the model Michael Ashley operates, is entirely about root cause analysis.
Getting down to the actual foundation of the problem.
Exactly. It's about identifying the underlying mechanical failure.
Yeah.
The actual physics of why your foot is in pain in the first place, and then addressing that instability right at its source.
Which brings up something really striking about the accessibility of his specific practice, because anyone who has navigated a chronic condition like diabetes knows the absolute nightmare of insurance approvals.
Oh, endless phone calls.
Waiting.
Oh, no.
Right. You need a referral. To get a referral, you wait 6 weeks for an appointment, and you still don't know what it's going to cost you.
It's exhausting for the patients.
But his clinic is cash-based. There is no insurance maze to get lost in. You don't even need a doctor's referral to walk through the door.
That is huge, that direct access.
Yeah, and he emphasizes incredibly fast appointments with totally transparent pricing. If you are in pain, you just go.
Which is how it should be.
But, okay, let me play devil's advocate for a second here.
Go for it.
Because I've been into those retail stores with the fancy pressure mapping machines, the ones.
Oh, I know exactly the ones you mean.
Yeah, you stand on the digital pad, it shows all the bright red spots where your foot has high pressure, and then the computer spits out a customized insole recommendation. Why isn't that piece of technology enough?
Well, what's fascinating here is the difference between a static snapshot and dynamic human movement.
Okay, static versus dynamic.
Right. A retail pressure mat is completely static. It only measures how you stand in one specific moment in time. But here's the thing. You don't walk statically.
Obviously not.
Walking is a highly dynamic, incredibly complex kinetic chain. It involves your joints, your tendons, the way your weight shifts, and your own unique gait cycle.
Right. Everybody walks a little differently.
Exactly. A machine that just maps static pressure cannot observe how your heel actually strikes the ground. It can't see how your foot rolls inward or, how your ankle might be compensating for a tight calf muscle when you were in mid-stride.
Wow, so it's missing all the action.
It really is. A board-certified Pedorthist with 2 decades of clinical experience isn't just looking at a colorful pressure map. They are analyzing the living dynamic mechanics of your entire body in motion.
Right, because if you just put a soft cushion under a static red spot without actually fixing the way the foot strikes the ground dynamically, you're just, moving that physical stress to another part of the foot?
Exactly, you're just shifting the burden.
You're ignoring the check engine light again. And for a diabetic patient, blindly shifting physical stress around is incredibly dangerous.
It can lead to disastrous complications.
So, since the retail guesswork is completely out, how does a podorthist actually map this out? Reading through the materials, Michael actually uses a very specific three-step clinical fitting process.
Yes, a very rigorous methodology.
And it really starts with a deep dive assessment that goes way beyond just looking at the bare foot, right?
Absolutely. The assessment phase, step 1, is the foundation of clinical podorthics. And you're right, they don't just look at the foot itself, they look at your old, worn-out shoes.
Really? Just regular old shoes?
Yeah. To a trained podorthist, an old shoe is like a fossil record of your gait.
Oh, that's such a cool way to think about it.
Isn't it? If the outside edge of the sole is completely worn down, but the inside looks brand new, that tells the clinician exactly how your foot is rolling and compensating during your stride.
So they're reading the wear and tear.
Exactly. They are analyzing your gait, mapping your specific pain patterns, and evaluating your overall posture to find the actual mechanical failure, not just the symptom.
So once he maps out exactly how your foot strikes the ground and where the mechanics are failing, what happens next? Because he can't just walk over to a wall of boxes and hand you a pre-made insert.
No, not at all. This is where we get to step 2, which is creating a custom solution plan. It is a highly deliberate selection process.
Like a personalized blueprint.
Exactly, a blueprint. It involves creating custom orthotics built from scratch to support your specific mechanics, paired with very deliberate footwear selection.
Okay, so the shoe and the insert are chosen together.
Right, but I want to be really clear here. Creating the device is only part of the equation. Where the real clinical magic happens is in step 3.
The precision fit and follow-up. I noticed the notes placed a massive emphasis on that fine-tuning phase. Why is that so crucial?
Because an orthotic doesn't exist in a vacuum. It exists inside a shoe. The mechanics of the custom orthotic and the structural properties of the footwear must work in perfect tandem. I mean, they absolutely have to.
You sound pretty passionate about this part.
I get so excited about this because people don't realize the physics involved. For example, let's talk about the shoe's heel counter.
Okay, what exactly is a heel counter?
It's the rigid, reinforced cup at the very back of the shoe that grips your heel bone.
Oh, I know what you mean, the stiff part in the back.
Yes. If the orthotic is perfectly crafted to stabilize your heel, but the shoe's heel counter is too soft and flimsy, your heel is still going to slip and slide, and the whole system fails.
So the great orthotic is ruined by the bad shoe.
Precisely. Or consider the break angle. That's the specific point where the shoe naturally bends across your toes when you push off the ground.
Okay, make a sense so far.
If the orthotic bends in one place, but the shoe's break angle is a half-inch further up, your foot is literally fighting the shoe with every single step.
Oh, wow, that sounds awful.
It is. That's why the follow-up and fine-tuning ensure that the footwear and the mechanics are harmonizing perfectly. A clinician will literally grind down foam layers by fractions of a millimeter or heat mold plastics right there on the spot to ensure that the orthotic and the shoe act as a single unified device.
That is serious precision.
It really is a closed-loop system of constant biomechanical refinement.
I love that phrase, closed-loop biomechanical refinement. But it makes total sense when you explain the actual physical elements fighting each other.
It really paints a picture, doesn't it?
It does. So this isn't just buying a suit off the rack. It's like going to a master tailor who actually makes you walk around in the suit, sit down, and climb a flight of stairs to see how the fabric pulls before they make the final stitch.
That is a brilliant analogy, but I'd go even further than that.
Oh, how so?
Because if the suit rips when you sit down, it's just embarrassing, right? But for a diabetic patient, a rip in this context means a blister, a deep tissue ulcer, or a severe infection.
Ah, yeah, the stakes are infinitely higher.
Exactly. It's not just about comfort, it's about preservation.
Which brings up something we really need to dig into, because that precise, fine-tuned fit becomes absolutely critical when dealing with feet that literally cannot slide into standard molds.
Why? Because standard shoes assume a standard foot shape.
Yeah, and in advanced diabetic care, foot deformities like bunions, hammer toes, or just incredibly hard to fit feet are a very common daily reality.
Yes, and we need to understand why those deformities happen in diabetic patients in the first place.
It's not just genetics.
Well, genetics play a role, but when diabetic neuropathy sets in, which is that dangerous loss of feeling in the extremities due to nerve damage, it doesn't just make the foot numb.
What else does it do?
It actually disrupts the nerve signals to the intrinsic muscles of the foot. Those tiny muscles begin to weaken and atrophy.
Oh, wow. I didn't realize that.
Most people don't. And when the muscles weaken, the tendons pull unevenly, and the actual bones of the foot begin to shift and change shape over time.
So it's literally pulling the foot out of alignment.
Exactly. That is exactly how you develop a hammer toe, where the toe curls up tightly and won't lay flat.
So suddenly, standard footwear isn't just uncomfortable, it becomes an active hazard.
Precisely. A standard shoe creates immediate friction points against those shifted bones. And friction on a foot that literally cannot feel pain is the primary catalyst for severe diabetic complications.
Because they can't feel the blister forming.
Right, they just keep walking on it until it becomes a massive ulcer.
And looking at Michael Ashley's practice, they lean heavily into custom solutions for exactly these types of hard-to-fit feet.
They have to. Standard retail won't cut it.
Right. They talk about bunion and hammer toe relief that prioritizes gentle correction and restoring natural alignment. They have specialized diabetic-safe footwear, seamless socks, therapeutic slippers, and sandals.
All designed to eliminate those friction points.
But there's one specific piece of gear mentioned in the notes that I really want to ask you about. They call it a diabetic neuropathy gauntlet. What exactly is that?
Ah, yes. A diabetic neuropathy gauntlet is a highly specialized, custom-molded ankle-foot orthosis.
Okay, what does that look like in plain English?
Think of it like a leather and plastic hybrid boot that laces up tightly around the foot and the lower calf.
Like a high-tech combat boot.
Basically, yeah.
Yeah.
It is designed to completely encapsulate the foot, locking the ankle and the foot into a stable, protected position.
They can't shift around.
Right. It essentially functions as a custom-molded suit of armor that prevents the joints from shifting and entirely eliminates the friction points that cause ulcers.
That is wild. I mean, I used to think that when someone had a severe deformity like a massive bunion, you just took a normal shoe to a cobbler and had them stretch the leather out to make room.
A lot of people think that, yeah.
Is that what's happening here? Are they just heavily modifying normal shoes?
Actually, no. Stretching a standard shoe compromises its structural integrity.
Oh, because you're weakening the material.
Exactly. If you stretch the leather, you weaken the support, and you can inadvertently create new, totally unpredictable pressure points elsewhere in the shoe.
That sounds like a recipe for disaster.
It is. What a certified Pedorthist does is engineer a custom solution designed from the ground up. You have to think about the physical barrier of protection required for someone with severe neuropathy.
Because they don't have their own natural warning system.
Right. They cannot rely on their own nervous system to tell them if a shoe is too tight, or if they have a blister forming, or if they stepped on a pebble.
The shoe essentially has to do the feeling for them.
Exactly. The footwear and the orthotic must act as a surrogate nervous system.
A surrogate nervous system. I love that concept.
It's the best way to describe it. They have to perfectly offload pressure and provide a flawless, frictionless barrier. It's treating the shoe as a highly engineered medical device, a vital shield, rather than just, an accessory you buy at a department store.
So what does this all mean for the absolute worst case scenarios? Because the need for that level of custom protective engineering reaches its absolute peak when a diabetic patient develops something called Charcot foot.
Yes. Charcot foot is arguably one of the most devastating and complex complications of diabetes.
It sounds intimidating just by the name.
It is. And to understand the severity, you really have to understand the mechanism behind it. We talked about how neuropathy causes muscle weakness.
Right. The muscles atrophying and pulling the bones.
Well, in Charcot foot, the neuropathy is so advanced and the blood flow is so compromised that the bones in the foot actually weaken to the point of fracturing.
Wait, really? The bones just break?
Yes, they fracture under the patient's own weight. But remember, the patient has profound nerve damage.
So they don't even feel their own bones breaking.
Exactly. They don't feel the microtraumas. They don't feel the stress fractures. So they just keep walking on it.
Oh, man. Here's where it gets really interesting. And by interesting, I mean incredibly daunting.
It is very daunting.
Because dealing with Charcot foot sounds like trying to reinforce the foundation of a house that is built on actively shifting soil.
That shifting foundation analogy is spot on.
If the bones themselves are breaking down and the structure is crumbling while the person is still walking on it, how does a pedorthist even begin to support that?
Well, if left untreated, those fracturing bones will completely shift. The arch of the foot can actually collapse downward, creating what we call a rocker bottom foot.
A rocker bottom foot?
Yeah, where the middle of the foot touches the ground instead of the heel and toes. It literally bows out the bottom.
Oh, that sounds incredibly painful. Even if they can't feel it, it sounds structurally disastrous.
It is. When that happens, The bone is practically pressing right against the skin on the bottom of the foot, creating massive pressure points that almost universally lead to severe limb-threatening ulcers.
So the Pedorthist is essentially stepping in to build an external scaffolding.
Yes, exactly. The materials from Michael Ashley's clinic outline a rigorous, three-pronged approach to Charcot foot. Early detection, aggressive protective solutions, and total stabilization.
So locking it all down.
Right. Using custom footwear and heavily modified rigid orthotics, the Pedorthist creates a structure to hold that shifting foundation in place.
So they aren't bearing weight on the broken parts.
Precisely. They are manipulating the physics of the patient's weight distribution, routing the physical impact of walking away from the midfoot so those weakened, fracturing bones aren't taking the brunt of the impact.
That is just brilliant engineering.
It really is. The singular focus is preventing that complete structural collapse of the foot.
It's just staggering to think about the mechanics involved in doing that successfully. You are literally engineering a way for someone to walk on fractured bones without destroying their foot.
It's incredible work, and if we connect this to the bigger picture, stabilizing Charcot foot isn't just about managing a localized issue in the foot.
No, it's way bigger than that.
It is a critical, life-altering intervention. When a Pedorthist successfully builds that scaffolding, stabilizes the foot, and prevents a total collapse, they're doing so much more than saving a limb.
They're saving the person's way of life.
Exactly. They're preserving that patient's entire independence. They're safeguarding their long-term mobility and their overall quality of life.
Because without
that specialized, highly educated clinical intervention, the cascade of complications from Charcot foot almost inevitably leads to complete immobility or even amputation.
it really puts the whole conversation into perspective, doesn't it?
It certainly does.
We started off talking about generic drugstore insoles, the flashing check engine light, and the frustration of retail guesswork.
Which seems so trivial now in comparison.
Totally, but when you look at the raw reality of diabetic foot care, from navigating the muscle atrophy of neuropathy, to building a surrogate nervous system with a gauntlet, to stabilizing bones that are actively fracturing under a patient's weight, it becomes crystal clear why you need a clinician with decades of experience.
You absolutely do.
You need someone who is assessing the dynamic, kinetic movement of your body, who is custom engineering a solution from the ground up, and who is endlessly fine-tuning that precision fit with grinders and heat molds until it is absolutely perfect.
And that is entirely about empowerment through clinical precision.
Beautifully said.
Whether you are managing your own diabetic health or you are trying to help a family member navigate this, knowing the immense difference between a retail store clerk and a board-certified Pedorthist is the key to moving better and hurting less.
Because the clerk is just selling a product.
Right. It's why demanding that level of root cause analysis and biomechanical precision in medical footwear should be absolutely non-negotiable for you.
Absolutely non-negotiable. It changes the entire trajectory of a person's health and their ability to just live their life.
Couldn't agree more.
And before we wrap up this deep dive, there was one final detail in the source materials that really stood out to me as something totally different from the clinical side.
Oh, the community aspect.
Yes. It's a section called DFW Community Wellness. Michael Ashley doesn't just wait inside his clinic in Cedar Hill for patients to come find him when they are already in a state of crisis.
Right. He gets out there.
He actively collaborates with local walking clubs, senior centers, churches, and neighborhood wellness groups to bring practical, hands-on foot health education directly out into the community.
And this raises an important question, doesn't it?
It really does.
Because we spend all this time discussing the incredible, highly technical clinical interventions that happen once a patient is sitting in the treatment chair. But that community outreach shifts the entire paradigm.
It completely flips the script.
It moves the focus away from reactive damage control and entirely toward proactive prevention.
Exactly. Which leaves you, the listener, with something really powerful to mull over today.
A big picture question.
Right. How might our society's entire approach to diabetic mobility fundamentally change if highly specialized clinical foot care was integrated directly into our everyday community spaces?
Just think about the impact of that.
Imagine if this level of expertise was just naturally a part of our local walking clubs and our neighborhood centers, rather than just waiting for patients to finally show up at a clinic when that check engine light has been flashing for far, far too long.